Usually when we talk about a medical diagnosis, there's this expectation of precision. It feels like engineering.
Right, like it's a math problem.
Yeah, exactly. You break your arm, the X-ray shows that jagged white line, and the doctor just points at the screen and says, there it is, broken.
And honestly, it's comforting because it's binary. I mean, the human brain loves a clear categorization, right? Especially when we're feeling vulnerable or sick.
Oh, absolutely.
Yeah.
But the deeper you go into human anatomy, the faster that illusion of precision kind of just vanishes.
Oh, for sure.
You step into the abdomen and suddenly that pristine X-ray machine is, it's basically useless. We're looking at a diagnostic landscape that is incredibly murky.
Yeah, murky is the perfect word for it.
And today we are taking you, our listener, right into the center of those muddy waters. We're jumping into this deep dive on an organ that almost never gets the spotlight until something goes terribly, terribly wrong. We're talking about the pancreas.
Which is a shame, honestly, because structurally and functionally, it is just one of the most fascinating organs we possess.
It really is. So we're going to treat the pancreas not just as a piece of biology, but as what it really is, which is a high-powered, incredibly volatile chemical factory.
That's a great way to think about it.
It sits deep in your abdomen, quietly running your metabolism, managing your digestion, keeping your blood sugar stable. It's an absolute powerhouse.
It's doing so much heavy lifting behind the scenes.
Right. But the question we are exploring today is, what happens when the containment protocols at that factory fail? Like, what happens when it leaks? Or, even stranger, what happens when it starts growing something completely alien to its design?
And when that factory malfunctions, I mean, the consequences are immediate. We are talking about severe pain, massive internal inflammation, and a cascade of biological events that can turn life-threatening in literally a matter of hours.
Terrifying. So our mission for this deep dive is to decode the often intimidating world of pancreatic fluid collections.
Right, which sounds like a lot of jargon.
It does. If you've ever heard words like pseudocysts, abscesses, or, pancreatic cysts, they can sound like a foreign language.
Totally.
Whether you are staring down a post-scan medical report that just popped up in your patient portal, or you're trying to make sense of what a loved one is going through in the hospital, we want to clear the fog.
We want to look at how the body reacts to a crisis, basically.
Exactly. And how doctors play detective to figure out what's really going on in the dark.
Because the terminology is complex, but the underlying mechanisms, like the body's desperation to protect itself, they're entirely logical.
Right.
Once we map out the architecture of this organ, the way things break down will just make perfect sense.
Okay, let's unpack this. To understand the leak, we first have to understand the normal day-to-day operating procedure of this chemical factory.
Yeah, the baseline.
We know the pancreas has two main jobs. There is the endocrine function, which is the famous one, right? Pumping insulin and glucagon directly into the bloodstream to manage your sugar levels.
The one everyone knows about.
Exactly. But we are actually leaving that aside today. We are focusing entirely on the exocrine function.
Right, and the exocrine system is really the heavy machinery of digestion.
Okay, break that down for us.
So the pancreas is constantly manufacturing a highly potent cocktail of digestive enzymes. I mean, these are biological solvents.
Solvent. Wow.
Yeah. You have amylase, which is designed to shear apart complex carbohydrates. You have lipase, which essentially dissolves fats. And you have the proteases, which are tasked with breaking down tough proteins into absorbable amino acids.
Okay, but think about what you just said. It breaks down protein and fat.
Right.
But the pancreas itself is made of protein and fat.
It is.
So my immediate question is, how does this factory not just, melt itself the moment it manufactures these chemicals?
Well, it relies on an incredibly elegant but super fragile packaging system.
Okay.
When the specialized cells in the pancreas, the acinar cells, when they create these enzymes, they don't produce them in their active, destructive form. They manufacture them as zymogens.
Zymogens.
Yeah.
Meaning they're dormant.
Exactly. They're basically inactive explosives.
Oh, I see.
The factory packs these dormant chemicals into tiny protective transport vehicles called vesicles, and then these vesicles are shipped out of the cells into the tiny branching ducts of the pancreas.
Like a microscopic plumbing system.
Right, which all merge into the main pancreatic duct. And this duct operates kind of like a massive flume ride, carrying the dormant enzymes out of the pancreas and dropping them into the duodenum.
Which is the very first section of your small intestine.
Exactly.
And that's the safe zone, right?
That is the containment chamber.
Oh.
Once they hit the intestine, a completely different enzyme, one that literally lives on the wall of the gut, acts as the detonator.
Wow.
It chemically cleaves the zymogens, activating them, and only then do they become the volatile solvents that can, dissolve a steak or a piece of cheese.
Which brings us to the nightmare scenario. Acute pancreatitis.
Yeah.
The system fails. The explosives detonate while they are still on the assembly line, inside the factory.
And the medical term for this is autolysis.
The pancreas literally digests itself.
It does. And it is as violent and destructive as it sounds.
I can't even imagine.
You have these industrial-strength solvents breaking out of their vesicles and leaking into the delicate ductal system and the surrounding cellular matrix.
So,
When this corrosive fluid leaks out into the retroperitoneum, which is the deep recessed space in the back of your abdomen where the pancreas sits, it just indiscriminately attacks whatever it touches.
like acid.
Exactly. It dissolves pancreatic tissue, it dissolves nearby fat, it attacks blood vessels.
Okay, but why? Why did the detonators go off early? What causes this catastrophic failure in the packaging?
Well, the mechanics usually come down to two primary culprits, which account for the vast majority of cases: gallstones and alcohol.
Okay, let's look at gallstones first, because I think it's a brilliant example of anatomical collateral damage.
It really is.
Let's trace the plumbing for a second. The liver makes bile, which is another digestive fluid, and stores it in the gallbladder.
Right. And when you eat a fatty meal, your gallbladder squeezes, pushing that bile down a tube called the common bile duct.
Okay.
Now, right before that bile duct enters the intestine, it merges with the main pancreatic duct. They form a Y junction.
Right.
So they actually share a single tiny exit door into the gut called the ampulla of Vater.
I see exactly where this is going. If a stone forms in the gallbladder and gets squeezed out.
It travels down the bile duct, and if it's the exact wrong size, it gets physically wedged right in that shared exit door. It plugs the drain.
So the bile backs up, but more importantly for us, the pancreatic juices back up.
Yes, and the pressure inside the delicate pancreatic ducts skyrockets. The factory is still producing enzymes, still pumping them out, but there is just nowhere for them to go.
It's a dead end.
Right. This massive hydrostatic pressure causes the tiny ducts to rupture. The acinar cells become incredibly stressed by the backup, the internal environment of the cell becomes acidic, and the lysosomes, the cell's own internal recycling centers, they malfunction. Yeah, they accidentally trigger the activation of the zymogens right there inside the cell.
So a mechanical traffic jam leads to a cellular stress response, which flips the detonator switch. Boom. Autolysis.
Exactly. Now compare that to alcohol, which operates through a completely different, much more insidious mechanism.
Right, and we should clarify, chronic heavy drinking doesn't just instantly dissolve the pancreas. It causes recurrent episodes of inflammation.
Exactly.
But how does a liquid sitting in your stomach and bloodstream attack the pancreatic ducts?
Well, alcohol fundamentally alters the chemistry of the pancreatic juice itself. It causes the acinar cells to secrete juice that is abnormally thick and rich in protein, but very, very low in fluid volume.
So it turns a flowing river into sludge.
A highly viscous sludge. And over time, these thick proteins precipitate out and form microscopic plugs. Literally, tiny little cords made of solidified protein blocking the smallest microscopic branches of the ducts. Furthermore, alcohol metabolism directly produces toxic byproducts inside the pancreatic cells, making those protective zymogen vesicles incredibly fragile.
So you have a combination of millions of microscopic roadblocks, plus transport vehicles that are prone to bursting open at the slightest provocation.
Exactly. And that's why an alcoholic binge can suddenly trigger an acute attack. The fragile cells are pushed to the absolute limit, they burst, the enzymes activate early, and the autolysis begins.
But those are the common ones, right? As we dive into the pathology, there are some triggers that sound like they belong in a totally different medical textbook. Mumps, for example.
Yeah, mumps.
I think of mumps as the virus that gives kids those giant swollen cheeks.
Right. Well, mumps is caused by a paramyxovirus, and this family of viruses has a very specific affinity for glandular tissue. It just loves to infect glands. The salivary glands are the most visible, hence the swollen cheeks, but the pancreas is also a massive gland. The virus can infiltrate the pancreatic tissue, replicate inside the cells, and trigger a massive inflammatory immune response that leads to acute pancreatitis.
That's wild. And what about metabolic issues, like too much calcium in the blood, hypercalcemia?
So calcium is a huge signaling molecule in the body. When calcium levels in the blood are dangerously high, maybe due to a parathyroid tumor or something, That excess calcium forces its way into the pancreatic cells.
Okay.
High intracellular calcium is actually one of the molecular triggers that activates the zymogens. It's essentially sending a false detonate signal to the explosives.
Wow. We also see medications on the list of culprits.
Right.
And these aren't rare exotic drugs either. We're talking about ACE inhibitors, which millions of people take daily for blood pressure.
Right.
We're talking about macrolides, which are super common antibiotics you might get for a stubborn sinus infection.
Yeah, drug-induced pancreatitis is relatively rare, but it's absolutely critical to watch for. And the mechanisms vary. Sometimes it's a direct toxic effect of the drug's metabolites on the pancreatic cells. Other times it's an idiosyncratic hypersensitivity reaction.
Like an allergy.
Essentially, yes. The patient's immune system mounts a bizarre, localized allergic response to the drug right inside the pancreas, causing profound inflammation.
Imagine taking a pill for a sinus infection and ending up with your pancreas dissolving itself. I mean, the human body is just relentlessly complex.
It really is.
So regardless of the trigger, stone, sludge, a virus, or a drug, the factory blows up. Corrosive acid is leaking into the deep abdomen, melting tissue.
Yes.
But the body obviously doesn't just sit there and let itself be destroyed. It goes into emergency containment mode.
Right. It launches a massive, desperate architectural project. And this is where the timeline of the disease becomes absolutely vital to understand.
Okay, let's walk through that timeline. In the immediate aftermath, say days 1 through maybe week 3, the area around the pancreas is total chaos, right?
Total chaos. Clinically, we call this early stage a peripancreatic fluid collection. And the key word there is collection.
Meaning it's not really structured.
Exactly. It is just a raw, unorganized pool. You have blood plasma weeping out of inflamed vessels. You have liquefied fat, dead cellular debris, and those active digestive enzymes all just sloshing around. It doesn't have a clear boundary. It's just shifting through the natural planes of the abdominal tissue.
It's a localized chemical spill spreading into the dirt.
Yes. But as we approach the 4-week mark, a profound shift occurs. The acute fiery inflammation starts to subside slightly, and the body transitions from acute damage control to chronic containment.
And that chaotic puddle matures into what we call a pseudocyst.
Right. The body walls off the caustic spill. It builds a definitive, thick, fibrous boundary, completely encapsulating the enzyme-rich fluid. But we call it a pseudocyst, a false cyst, because of what is missing.
Right, let's break down that terminology because it might sound pedantic, but it's biologically crucial.
It is.
If I have a normal cyst, say on my kidney or my skin, what makes it a true cyst?
Well, a true cyst is essentially a biological balloon that grew from scratch. The inside of that balloon is lined with a continuous sheet of specialized cells called an epithelium.
Okay.
Those epithelial cells are alive, and they actively secrete the fluid that fills the cyst. So the structure was really built from the inside out.
But this pancreatic pseudocyst is totally different. It wasn't grown, it was built defensively.
Exactly. It has zero epithelial lining. It is literally just a cavity, a void in the tissue that was carved out by the corrosive acid.
Wow.
The walls of this cavity aren't made of specialized secreting cells. They are made of thick scar tissue, heavy collagen, and frequently the body just commandeers whatever organs happen to be nearby to act as part of the wall.
I picture it exactly like a hastily built sandbag wall trying to contain a toxic chemical spill.
That's a perfect analogy.
The emergency responders didn't have time to build a proper lined steel storage tank. They just grabbed sandbags, old tires, the side of a nearby building, whatever was available to hold back the flood.
Right.
So in the abdomen, the body uses the backside of the stomach, loops of the colon, the omentum. It just glues them all together with scar tissue to form a perimeter.
That is precisely what happens. The severe inflammation makes the surfaces of the surrounding organs incredibly sticky, physically adhering them together to seal the leak.
But this brings up a massive paradox for me.
Okay, what's that?
If this fluid is actively digesting protein and fat, like if it's literally dissolving human tissue, how on earth does the body manage to build a wall out of tissue to contain it? Why doesn't the stomach wall or the scar tissue just get melted the second it touches the fluid?
Right. Well, it's one of the most dynamic battles in human physiology. You really have to stop thinking of the pseudocyst wall as a static structure like a brick wall.
Okay.
It is a war zone in a state of violent equilibrium, a relentless race. On the inner surface of the cyst, touching the fluid, the corrosive enzymes are indeed actively digesting the tissue. The inner layer is constantly necrotizing and sloughing off.
It is melting.
It is. But simultaneously, the body's immune system has flooded the outer perimeter with millions of fibroblasts.
The builders.
Right. Fibroblasts are the construction workers of the cellular world. They are frantically synthesizing and laying down dense, tough collagen fibers, heavy scar tissue on the outside of the wall.
Oh, wow. So they're throwing new sandbags on the outside of the wall just as fast as the acid is eating away the sandbags on the inside?
Exactly. And as long as the fibroblasts can lay down collagen faster than the enzymes can dissolve it, the wall holds.
That's incredible.
Over the course of 4 to 6 weeks, the initial concentration of enzymes begins to dilute, the acute inflammation cools down, and that thick, fibrotic capsule finally thickens enough to stabilize the entire structure.
That is just an incredible feat of biological engineering. So now the patient has this walled-off sphere of fluid sitting in their abdomen.
Yeah.
It's stable. I mean, it might be causing symptoms. Maybe it's so large it's physically squishing the stomach, making them feel full after 3 bites of food, or causing persistent aching pain in the back. But the chemical fire is mostly contained.
And often it's managed conservatively. We give the patient supportive care, control their pain, ensure they're nourished, and we just wait.
Because miraculously, these things can disappear, right?
They can.
I've read that the vast majority of uncomplicated pseudocysts will just slowly resolve on their own over several months. But again, I have to push back on the mechanics of that.
Okay, go for it.
If you have a pool of extremely corrosive pancreatic juice and the body reabsorbs it, where does it go? Doesn't sucking toxic enzymes back into the bloodstream just poison the patient?
It would, absolutely, if the body didn't have neutralizing countermeasures. Your blood serum actually contains highly specialized proteins called protease inhibitors.
Anti-enzyme.
Essentially, yes. Alpha-1 antitrypsin and alpha-2 macroglobulin. As the pseudocyst slowly leaks microscopic amounts of fluid into the surrounding lymphatic system and capillaries, these inhibitors immediately bind to the digestive enzymes, permanently deactivating them.
Oh, so they lock them down.
Right. Once they are locked up and safe, the liver and kidneys can filter them out as waste. Simultaneously, the water content of the cyst is slowly pulled back into the venous system.
All right.
As the pressure drops, the walls of the cyst collapse inward, and eventually the scar tissue remodels and fades.
The body cleans up the battlefield and absorbs the weapons safely. That is the best case scenario.
Definitely the best case.
But what happens when the perimeter is breached? What happens when that sterile, walled-off chemical spill suddenly gets invaded by a foreign enemy?
Oh, things get very bad.
Right. This takes us to an entirely different level of danger. The pancreatic abscess.
Right. A pseudocyst is an inflammatory problem. A pancreatic abscess is an infectious catastrophe. It is a circumscribed intra-abdominal collection of pus. You have the original enzyme fluid, cellular debris, and now rapidly multiplying bacteria.
And the moment infection sets in, the mortality risk just skyrockets.
It really does.
And when you look at the specific bacteria causing these abscesses, it's a very distinct lineup. We aren't talking about skin bacteria or lung bacteria here.
No.
We're looking at the heavy hitters of the gut biome: gram-negative colonic flora, Escherichia coli, Klebsiella, Pseudomonas, and gram-positives like Enterococcus.
Right. These are organisms that evolved to live, thrive, and remain safely contained within the massive dark fermentation vat that is your large intestine.
Which makes no geographical sense.
I know, it sounds weird.
The colon is a sealed tube. The pancreas is in a completely different compartment of the abdomen, the retroperitoneum.
Yeah.
The pseudocyst is surrounded by an impenetrable wall of dense scar tissue. How exactly does E. coli manage to travel from the inside of the colon, across multiple anatomical barriers, and perfectly locate this sealed-off pocket of fluid?
It sounds impossible, but it is driven by a phenomenon called bacterial translocation.
Okay.
To understand it, you have to look at what is happening to the entire body of a patient with severe pancreatitis.
Yeah.
They aren't just experiencing localized belly pain, their entire physiology is reacting to the trauma.
They are entering SIRS, right? Systemic Inflammatory Response Syndrome.
Yes. SIRS is basically the body's immune system going nuclear. The localized inflammation in the pancreas dumps massive amounts of signaling proteins called cytokines into the systemic bloodstream.
Like setting off every alarm in the building.
Exactly. These cytokines circulate everywhere, telling every blood vessel in the body to dilate and become leaky to allow white blood cells to hunt for imaginary enemies.
It's a massive overreaction.
A profound overreaction, and one of the most critical casualties of the systemic inflammation is the mucosal barrier of the intestines. The gut is normally lined by a single layer of cells held tightly together by protein complexes, literally called tight junctions. They act as the security gates, allowing nutrients to pass into the blood while keeping the trillions of gut bacteria locked inside the intestine.
But the inflammation breaks the locks.
The severe systemic stress causes those tight junctions to fail. The security gates swing wide open. The gut wall becomes permeable.
So the bacteria aren't chewing their way out, the doors just fall off the hinges.
Precisely. Macrophages, a type of immune cell, sometimes even mistakenly swallow these bacteria, carry them across the broken gut barrier, and instead of killing them, act as a taxi service, releasing them into the local lymphatic system or the portal bloodstream.
The bacteria are in the transit system. But why do they end up in the pancreas?
Well, they end up everywhere. But if a stray E. coli bacterium floats through the bloodstream and lands in healthy muscle tissue, the local immune cells immediately destroy it.
Sure.
But what happens if that bacterium is swept into the capillaries surrounding a pancreatic pseudocyst?
It finds a zone of dead tissue.
It finds an area with compromised blood flow, meaning fewer immune cells can reach it. And inside that cyst is a warm, stagnant pool of liquefied proteins and sugars.
Ugh.
It is the ultimate biological incubator. The bacteria cross into the cyst, realize they have unlimited food and no immune system to fight them, and they just begin to multiply exponentially.
The sterile chemical spill becomes a massive expanding pocket of pus.
Yeah.
So, put yourself in the shoes of the medical team. You have a patient hospitalized for acute pancreatitis. They are on IV fluids, they haven't eaten solid food in a week to let the pancreas rest, and they are on heavy pain meds.
Right.
How do you know the precise moment a sterile cyst turns into an infected abscess?
The clinical picture changes violently. Usually, with supportive care, a pancreatitis patient slowly improves after a week. Their pain dulls, their heart rate settles down, but if an abscess forms, they suddenly hit a wall or rapidly deteriorate.
The alarms go off.
The patient spikes a high swinging fever, their heart rate shoots up to 120 beats per minute. Their blood pressure starts to sag dangerously low as the bacteria release toxins into the bloodstream. They develop rigors, like uncontrollable shaking chills. The abdominal pain, which had been manageable, suddenly becomes excruciating and diffuse.
They're going into septic shock.
Exactly.
So the doctors immediately draw blood.
Yeah.
But you can't just look at a basic blood test and point to a number that says pancreatic abscess.
You can't, but you can look for the biochemical shock waves of the infection. We look very closely at a marker called CRP, C-reactive protein.
Break down CRP for us. What is it and why does it matter here?
Well, CRP is a protein synthesized by the liver. When tissues anywhere in the body are severely damaged or necrotizing, like dying, local immune cells release a distress signal called interleukin-6.
Okay.
The liver detects this IL-6 in the blood and immediately starts pumping out massive quantities of C-reactive protein. CRP's job is to bind to the surface of dead or dying cells and tag them so the immune system can clear them away.
It's a biological flag marking the casualties.
Exactly. A normal CRP level is basically 0. In a patient with severe pancreatitis, we look for a critical threshold.
What's the number?
Clinical studies have shown that a CRP level soaring above 150 milligrams per liter is an incredibly ominous sign.
150, wow.
While it doesn't specifically say bacteria, a level that high is deeply correlated with extensive tissue necrosis in the pancreas. And where there is massive necrosis, there is the perfect breeding ground for an abscess.
But there is another clue in the blood work that absolutely fascinates me. Hematocrit.
Oh, yes.
Hematocrit is simply the percentage of your blood volume that is made up of red blood cells. A normal level is around 40 to 45%. The literature states that a hematocrit higher than 44% upon admission is a major risk factor for developing an abscess later.
That's right.
Why does slightly thick blood predict a pancreatic infection weeks down the line?
This is one of the most brilliant pieces of physiological deduction in medicine. It's not that the red blood cells cause the infection, it's that the high hematocrit is a glaring warning sign of profound hemoconcentration.
Meaning the blood has lost its water.
Remember SIRS, the systemic inflammation.
Yeah.
We discussed how it makes the blood vessels leaky. In severe pancreatitis, the capillary beds in the abdomen become so permeable that massive amounts of blood plasma, the liquid water part of the blood, just weep out of the circulatory system and pool uselessly in the spaces between the abdominal organs.
So the fluid is just sitting in the abdomen.
We call this third spacing.
The patient is bleeding out internally, but they are only bleeding water.
Exactly. And because the vascular system is losing water, the red blood cells left behind become incredibly concentrated. The blood basically turns to sludge.
like trying to pump red cement through the veins.
And that is the legal problem. If the blood is sludge, it cannot flow smoothly through the microscopic capillaries feeding the pancreas. The tissue becomes ischemic, it starves for oxygen.
And tissue that starves dies.
It necroses. And as we established, massive necrosis provides the perfect dead environment for translocating bacteria to set up shop. So a high hematocrit on day 1 tells the doctor, this patient has a massive, leaky, inflammatory response right now. They are going to develop dead tissue, and that dead tissue is going to get infected.
That is the medical equivalent of looking at dropping barometric pressure and knowing a hurricane is coming. It's beautiful, terrifying logic.
It really is.
So the blood work suggests an infection. The patient is crashing. You need to see the abscess to confirm it.
We immediately order an abdominal CT scan with IV contrast. It gives us a high-resolution, three-dimensional map of the entire abdomen.
And the radiologist is looking for a very specific smoking gun, something that proves bacteria have infiltrated the fluid collection.
They are scanning the fluid pockets around the pancreas for something that absolutely should not exist inside solid human tissue. Gas.
Extraluminal gas, air bubbles.
Human cells do not produce gas, but those gut bacteria we talked about, the E. coli and Klebsiella, they are highly metabolically active.
Yeah.
As they gorge themselves on the dead tissue and proteins inside the cyst, they undergo fermentation. And a byproduct of that bacterial fermentation is gas.
They are essentially burping inside the cyst.
Basically. If the radiologist scrolls through the CT scan and sees a dark, fluid-filled mass peppered with tiny black pockets of air, that is definitive proof of an abscess. The perimeter has been breached, and the enemy is rapidly multiplying.
And the response has to be overwhelming. Untreated, an infected pancreatic abscess is a death sentence.
Oh, without question.
The mortality rate approaches 100%. The patient will spiral into multi-organ failure, their kidneys will shut down, their lungs will fill with fluid, and they will die.
The first line of defense is pharmaceutical, but it requires highly specific pharmacology. You can't just give them a standard oral antibiotic.
Because it won't reach the target.
Right. You have a massive sphere of pus surrounded by dense scar tissue with terrible blood flow. A standard antibiotic will just bounce off. We have to use incredibly potent, broad-spectrum intravenous antibiotics like the carbapenem class because their molecular structure allows them to physically penetrate that dense fibrotic wall and achieve high concentrations inside the dead pancreatic tissue.
But antibiotics alone aren't enough to clear a grapefruit-sized pocket of thick pus. You can't just sterilize it. You have to evacuate it. You have to drain the swamp.
And how we achieve that drainage is one of the most critical decision points in surgery. It entirely depends on how sick the patient is in that exact moment.
Right.
Are they hemodynamically stable or are they unstable?
Let's take the worst-case scenario. They are unstable. Their blood pressure is crashing. They are on vasopressor drugs just to keep their heart pumping. They're in septic shock.
If they're crashing, you don't have time for elegance. You need immediate, definitive source control.
Okay.
The patient is rushed to the operating room for an open surgical debridement. The surgeon makes a massive incision down the center of the abdomen, physically pushes the stomach and intestines out of the way, and opens the retroperitoneum.
They literally scoop out the dead tissue.
They bluntly dissect out the necrotic, black, infected pancreatic tissue, suction out the pus, wash the cavity with liters of saline, and leave multiple large surgical drains sticking out of the patient's abdomen to ensure any remaining pus has a way out.
That sounds brutal.
It is a brutal, highly invasive surgery on a patient who is already at death's door, but it is the only way to save their life.
It's the ultimate salvage operation. But what if they are stable? What if the antibiotics have contained this shock and the patient is holding their own?
Well, if they are stable, we avoid the massive trauma of open surgery. We use minimally invasive methods, and the gold standard now is endoscopic necrosectomy and drainage.
Going in through the mouth.
Exactly. We use the body's natural pathways to reach the abscess, drain the pus from the inside, and avoid cutting the skin altogether. We will dive into the incredible mechanics of exactly how that works in a moment, because the technology is basically science fiction, but it represents a massive paradigm shift in how we handle these fluid collections.
It truly does. So we have spent the first half of this deep dive exploring the explosive, violent aftermath of pancreatitis.
Yeah.
We've talked about the initial chemical leak, the desperate construction of the protective pseudocyst, and the terrifying prospect of that cyst becoming a bacterial war zone. These pathologies announce themselves loudly.
Very loudly.
You have excruciating pain, you have skyrocketing fevers, you are vomiting, you are acutely aware that you are in deep trouble.
You are definitely taking an ambulance to the emergency room.
Right. But what about the anomalies that don't announce themselves? What about the things lurking in the pancreas in total silence?
That's a whole different ballgame.
This transitions us to the other side of the diagnostic coin, the accidental discovery. We're talking about true pancreatic cysts.
This is a completely different clinical scenario, and quite frankly, it is becoming an epidemic of discovery in modern medicine.
The epidemiology here absolutely blew my mind. Pancreatic cysts are found incidentally, meaning by pure accident, in roughly 2% to 20% of all patients undergoing a high-resolution CT or MRI for completely unrelated reasons.
Let's contextualize that right. You are driving to the grocery store. You get into a minor fender bender. Your neck hurts, maybe your ribs ache.
Okay.
You go to the ER, and to be safe, the doctor orders a CT scan of your chest and abdomen to rule out internal bleeding.
Standard protocol.
The radiologist reads the scan. No broken ribs, no bleeding. But at the bottom of the report, there is a one-line note. Incidentally noted, a 1.5 centimeter cystic lesion in the tail of the pancreas. Clinical correlation recommended.
Wow. So up to 1 in 5 people walking around right now might have one of these? And if you are older or if you have a strong family history of pancreatic issues, the prevalence jumps even higher.
Exactly.
That is a massive portion of the population walking around with bubbles on their pancreas, completely oblivious.
And it is entirely driven by the sheer volume of high-resolution imaging we do today.
Makes sense.
20 years ago, CT scanners weren't crisp enough to see a 1 centimeter fluid bubble. Today, the resolution is exquisite. We are looking closer than ever before, so we are finding things we used to happily miss. We call them incidentalomas.
But finding a cyst is only half the battle, because then you have to figure out what kind of cyst it is. And unlike the pseudocysts we just talked about, which is a reaction to a chemical burn, these are true cysts.
Right. They have that continuous living epithelial cellular lining. They are biologically active structures growing inside the pancreas.
And they are broadly divided into two terrifyingly distinct categories. On one hand, you have the non-neoplastic cysts. These are benign.
Right.
They have essentially zero risk of turning into cancer. On the other hand, you have the neoplastic cysts. These are either already malignant or they are precancerous time bombs.
And the stakes of differentiating between the two are monumentally high. This is the hardest tightrope walk in gastroenterology.
Because if you get it wrong, the consequences are disastrous in both directions.
Exactly. If you look at a scan and misdiagnose a completely harmless, benign cyst as a developing cancer, you panic.
Right.
You send the patient to surgery to have half their pancreas removed. They suffer through a massive, life-altering operation, endure months of painful recovery, and perhaps become a brittle diabetic for the rest of their life for absolutely no reason. The cyst was never going to hurt them.
But if you flip the error,
if you look at a precancerous mutating cyst and say, it's small, it's probably nothing, let's just ignore it, you have just missed the only window of opportunity to cure a lethal cancer before it spreads.
which is horrifying.
Pancreatic cancer is notoriously aggressive. By the time it causes symptoms, it is almost always too late. These cysts give us a rare chance to catch it early.
So we have to know what we're looking at. Let's unpack the roster of these cysts. Let's start with the non-neoplastic, the good guys, so to speak. If you have to have a cyst, these are the ones you want.
The most common benign true cyst is the serous cystadenoma. These are usually microcystic.
Meaning they aren't one big balloon, but a cluster of tiny balloons.
Yes. They are composed of hundreds of tiny individual fluid pockets separated by thin walls of fibrous tissue. The fluid inside is thin and watery, like blood serum, hence the name serous.
Now, a radiologist looking at a black and white CT scan needs clues. And there is a specific visual pattern for these serous cystadenomas that is practically a guarantee of what it is.
We look for a pathognomonic sign. Pathognomonic means that if you see this specific feature, the diagnosis is essentially certain. On imaging, a microcystic serous cystadenoma has a distinct honeycomb appearance.
Like a literal beehive.
Exactly. Dozens of tiny septated cysts clustered together, and right in the middle of the honeycomb, there's often a dense, star-shaped piece of fibrous tissue called a central stellate scar.
Okay.
Sometimes that scar even calcifies, so it glows bright white on a CT scan. If a radiologist sees a honeycomb with a calcified central sunburst scar, they can confidently tell the patient, this is benign, go live your life.
which is a huge relief.
Hmm.
You also have simple cysts, which are just uninteresting little bubbles of fluid. And then there's a bizarre one called a lymphoepithelial cyst.
Oh, they are fascinating from a microscopic perspective. If you surgically remove one and hand it to a pathologist to slice open and look under a microscope, the architecture is totally unexpected for the pancreas.
What do they see?
The inside of the cyst is lined with mature squamous cells. Squamous cells are flat, scale-like cells. It's the exact same type of cell that makes up the outer layer of your skin or the lining of your esophagus.
Wait, skin cells in the pancreas.
Yes. And just beneath that skin-like lining, the cyst wall is packed densely with sheets of benign lymphocytes, which are the white blood cells of your immune system.
So it's a little ball of skin and immune cells hiding in the pancreas.
Exactly. We aren't entirely sure why they form, possibly from displaced cellular remnants during fetal development, but they are entirely benign. They have zero malignant potential.
Okay, so those are the ones that let everyone sleep at night. But now we have to talk about the bad actors, the neoplastic cysts, the ones that keep doctors up at night staring at scans.
The heavy hitters in this category are the Intraductal Papillary Mucinous Neoplasms, commonly known as IPMNs.
Let's break down that mouthful of a name, because every word tells you exactly what it's doing. Intraductal.
Meaning it grows entirely inside the existing plumbing system of the pancreas. It arises from the cells that line the ducts.
Papillary.
It doesn't grow flat. It grows in tiny finger-like fronds or projections called papillae, reaching out into the stream of the duct.
And mucinous.
This is the most dangerous part. These tumor cells produce mucin. Mucin is a thick, highly viscous, jelly-like glycoprotein. It's the same substance that makes up the mucus in your lungs or your nose.
So you have finger-like tumors growing inside the delicate pancreatic pipes, pumping out thick jelly.
You can imagine the mechanical problems that causes. The thick mucin clogs the ducts, causing them to balloon outward, which is what creates the cystic appearance on the scan. It's a backed-up pipe.
And we categorize these IPMNs based on which pipes they choose to grow in.
Yes. Main duct IPMNs grow right inside the primary central plumbing line that runs the entire length of the pancreas.
Okay.
These are highly dangerous. The risk of them harboring invasive cancer is incredibly high, often over 60%.
And then you have branch duct IPMNs.
These grow in the smaller side channels that feed into the main duct. They are much more common and thankfully have a significantly lower rate of malignant transformation. And finally, mixed IPMNs, which involve both the main thoroughfare and the side streets.
Beyond IPMNs, you have solid pseudopapillary neoplasms, which are these large, distinct tumors that usually show up in young women and are a mix of solid tissue and fluid spaces.
Right.
And you have cystic pancreatic neuroendocrine tumors, which are often tied to genetic syndromes. But the one neoplastic cyst that really stands out to me, purely from a biological mystery standpoint, is the mucinous cystic neoplasm.
Ah, yes. These are large, thick-walled cysts that produce massive amounts of mucin. But unlike IPMNs, they do not communicate with the ductal system. They are totally separate spheres growing in the pancreatic tissue.
But the truly wild part is how pathologists definitively diagnose them under a microscope. They look for a specific type of tissue in the wall of the cyst called ovarian-type stroma.
Right. Stroma is just the generic medical term for the supportive structural connective tissue of an organ. It's the scaffolding.
Okay.
But in these specific pancreatic cysts, the scaffolding tissue physically and chemically resembles the stroma normally found only in a woman's ovary. It even has receptors for estrogen and progesterone.
Wait, let's pause on that. You were saying there's literally tissue identical to an ovary growing right in the middle of the pancreas.
Yes.
How is that physically possible? The ovaries are in the deep pelvis. The pancreas is up near the stomach. How does a piece of an ovary end up there?
To understand this, we have to rewind the clock all the way back to the first few weeks of fetal development. When a human embryo is forming, it is essentially a flat disk of cells that undergoes incredibly complex folding.
The origami of human life.
It is exactly like origami. Tissues that start out right next to each other get pulled, stretched, and folded to opposite ends of the body.
Right.
During this embryological folding, the primitive gut tube, which will eventually bud off to form the stomach, liver, and pancreas, is located intimately close to a structure called the urogenital ridge.
The urogenital ridge is what eventually drops down to become the kidneys and the gonads, the ovaries or testes.
Exactly. They are microscopic neighbors in the first month of gestation. The prevailing theory is that during this chaotic folding and migration of embryonic tissue, a tiny cluster of primordial ovarian cells accidentally gets caught in the crossfire.
Oh, wow.
It gets incorporated into the budding pancreas and gets trapped there as the organ solidifies.
It's a developmental typo, a copy-paste error from the womb.
A typo that lies completely dormant for decades. But 50 or 60 years later, perhaps stimulated by decades of fluctuating hormones, that tiny remnant of misplaced ovarian tissue awakens, starts proliferating, forms a cyst, and begins pumping out mucin.
That is absolutely mind-blowing. It's a biological time capsule revealing itself on a random CT scan half a century later.
It's incredible biology.
But as fascinating as that is, it brings us back to the stark clinical reality.
True.
The doctor is looking at a gray blob on a computer screen. It could be a harmless honeycomb serous adenoma, or it could be an IPMN actively mutating into lethal pancreatic cancer.
And you can't just slice the patient open to take a quick look.
Here's where it gets really interesting. I look at this clinical dilemma like trying to guess what is inside an opaque sealed box. You aren't allowed to open the box because doing so might kill the patient. Yep. So how do you figure out what's inside?
You have to systematically look for external clues, evaluate the structural integrity of the box, and, if absolutely necessary, find a highly advanced, minimally invasive way to slip a needle into the box and pull out a sample.
Which perfectly sets up the crucial next phase of our journey, the decision matrix.
Right?
How do gastroenterologists, radiologists, and surgeons combine imaging, high-tech ultrasound, and fluid analysis to make the agonizing choice between cutting the pancreas out or just sitting back and watching?
The very first step is looking closely at the outside of the box, the high-resolution MRI or CT scan. Medical societies have developed incredibly strict evidence-based guidelines. We scan the images looking for what we call high-risk stigmata or worrisome features.
What are the red flags? If I'm looking at my own scan report, what words should make me nervous?
Size is the most basic metric. Any cyst that has grown larger than 3 centimeters in diameter crosses a threshold of suspicion. The larger it is, the more time it has had to mutate. Next, we look very closely at the walls of the cyst. A benign cyst usually has a paper-thin, perfectly smooth wall.
Makes sense.
If the radiologist notes that the cyst wall is thickened, or if there are solid mural nodules, which are essentially little lumpy tumors growing on the inside surface of the cyst wall, that is highly concerning for invasive cancer.
They also measure the main pancreatic duct itself.
We do. A normal pancreatic duct is tiny, maybe 2 or 3 millimeters across.
Okay.
If the duct is dilated to greater than 5 millimeters, or certainly greater than 10 millimeters, it implies 2 terrifying things. Either a mucinous cyst is pumping out so much jelly that it is physically obstructing the flow, causing upstream pressure, or the cyst is a main duct IPMN, which, as we discussed, carries a massive risk of malignancy.
And lastly, they check the surrounding neighborhood for lymphadenopathy.
Swollen lymph nodes adjacent to the pancreas. If the lymph nodes are enlarged, it is a classic ominous sign that a cancer has already breached the walls of the cyst and is beginning to spread through the lymphatic system.
So if a patient has these high-risk features, like a 4-centimeter cyst with a solid nodule inside it, the decision is usually clear. You need surgery. But what if the scan is ambiguous? What if it's 2.5 centimeters, no nodules, but it looks a little strange? You don't want to jump to a massive surgery, but you can't ignore it. You need to look inside the box.
And this brings us to the technological marvel of pancreatic diagnostics, EUS-FNA, endoscopic ultrasound with fine needle aspiration.
This technology completely revolutionized the field. Let's provide some context. Before this existed, if a doctor wanted to test the fluid inside a pancreatic cyst, how did they do it?
They had to use a percutaneous approach. Percutaneous meaning through the skin.
Right.
A radiologist would literally take a long, hollow needle and drive it straight through the skin of the patient's abdomen, pushing through layers of abdominal muscle, carefully dodging the liver, the stomach, the intestines, and major blood vessels, hoping to accurately spear a tiny fluid bubble deep in the retroperitoneum.
It sounds like trying to hit a bullseye with a dart while blindfolded, shooting through a crowded room.
It was incredibly risky. It was prone to sampling errors because the ultrasound imaging from outside the body was degraded by passing through so much fat and bowel gas, and there was a real risk of accidentally puncturing the stomach or causing a severe hemorrhage.
So what makes endoscopic ultrasound, EUS, so vastly superior?
It leverages the body's natural internal anatomy to bypass all those obstacles. Instead of going through the skin, the gastroenterologist passes a long, flexible endoscope down the patient's throat, through the esophagus, and into the stomach in the duodenum.
We've all seen pictures of an endoscope. It's a tube with a camera and a light on the end. But an EUS scope has a special attachment.
The tip of the scope features a miniaturized high-frequency ultrasound probe.
And why is that positioning so critical?
Because of where the stomach sits.
Yeah.
The back wall of the stomach and the curve of the duodenum are literally resting directly on top of the pancreas. They are touching it.
Oh, I see. So instead of trying to look at the pancreas through 6 inches of abdominal fat and intestines, you were looking at it from the inside out.
You are imaging the pancreas from a distance of maybe 2 or 3 millimeters. There is nothing blocking the sound waves. The spatial resolution is staggering.
Wow.
The doctor can see the exact microscopic thickness of the cyst wall. They can spot tiny, millimeter-sized mural nodules that a CT scan would completely miss. They can trace the ductal system in real time, watching exactly how the cyst connects to the plumbing.
But EUS is only half the acronym. The real magic is the FNA, fine needle aspiration.
Right. Once the doctor has positioned the ultrasound probe perfectly against the stomach wall directly over the cyst and verified with Doppler ultrasound that there are no blood vessels in the way, they advance a tiny hollow needle out of the tip of the endoscope.
Okay.
The needle pierces seamlessly through the thin wall of the stomach, travels a few millimeters, and punctures directly into the center of the pancreatic cyst.
They hook up a syringe to the handle of the scope, apply suction, and aspirate, suck out a small sample of the fluid from inside the cyst. Then they retract the needle, pull the scope out, and the tiny puncture hole in the stomach heals almost instantly.
It is incredibly safe and overwhelmingly accurate.
So now, the lab has a little vial of fluid from inside the sealed box. What exactly are they testing it for? What are the chemical fingerprints that reveal the identity of the cyst?
We run a panel of biochemical markers, but the decision tree relies primarily on 2 main substances, amylase and CEA.
We know amylase. That's the highly potent digestive enzyme the factory produces to break down carbohydrates.
Exactly, and the second marker is CEA, which stands for carcinoembryonic antigen.
What is CEA? Why would a cyst produce it?
CEA is a complex glycoprotein that is involved in cell adhesion, helping cells stick together. It is heavily produced during fetal development, but production usually stops before birth.
Okay.
However, certain types of tumor cells, specifically mucin-producing tumors like IPMNs and mucinous neoplasms, revert to this primitive state and start overproducing CEA. It leaks into the cyst fluid.
Okay, so the lab runs the fluid through the analyzer, and the results come back. It's essentially a logic puzzle. Scenario 1. The fluid is extremely low levels of CEA, practically 0, but the amylase levels are off the charts, in the tens of thousands. What is it?
That biochemical fingerprint tells you definitively that you are dealing with a pseudocyst.
Why?
Because high amylase means the cyst fluid is just leaked pancreatic juice. It's connected directly to the ductal plumbing where the enzymes flow.
Right.
And the low CEA confirms that there are no mucin-producing tumor cells lining the cyst. It's just an inflammatory puddle.
Okay, scenario 2. The amylase is low, but the CEA is incredibly high. It crosses a highly specific clinical threshold established by years of pathology data.
If the CEA is elevated significantly above that diagnostic cutoff, the alarm bells ring. High CEA is the hallmark signature of a mucinous cyst.
It's pumping out tumor jelly.
Exactly. The doctor can confidently diagnose it as a potentially malignant mucinous neoplasm like an IPMN or an MCN. The high CEA tells us there is a living, mutating epithelial lining producing that fluid.
And finally, scenario 3. The CEA is rock bottom, extremely low, and the amylase is also extremely low.
That combination strongly points toward our benign friend, the serous cystadenoma, that harmless honeycomb cyst.
Oh, okay.
It doesn't connect to the main pancreatic pipe, so there is no amylase leaking into it, and it's composed of serous cells, not mucinous cells, so it doesn't produce any CEA.
It's an incredibly elegant system of deduction, but surely they don't just rely on chemistry, don't they look at the actual cells under a microscope? Cytology.
We do send the fluid to cytology. A pathologist spins the fluid in a centrifuge to concentrate any solid material, stains it, and looks for malignant, misshapen cancer cells.
But I understand there's a massive caveat to cytology in this specific context.
A huge caveat. The diagnostic yield of cytology for pancreatic cysts is notoriously poor.
Why? If it's a cancer cyst, shouldn't it be full of cancer cells?
You have to remember the physics of a cyst. It is 99% fluid, water, and protein. The actual tumor cells are firmly attached to the inside wall of the cysts.
Oh, I see.
Only a very small number of cells naturally die and slough off into the fluid. We call this low cellularity.
So it's like scooping a cup of water out of a massive lake and hoping to catch a fish.
Precisely. If the pathologist looks at the slide and sees definitive cancer cells, that is a home run. The diagnosis is confirmed.
Right.
But, and this is the critical trap for young doctors, if the cytology comes back negative for malignant cells, it absolutely does not mean there is no cancer.
It just means your tiny needle didn't happen to suck up a cancer cell in that specific milliliter of fluid.
Exactly. The absence of evidence is not evidence of absence. That is why we rely so heavily on the biochemical markers like CEA and the high-resolution US imaging to make the final call.
Okay, so we've solved the mystery of the box. We have a diagnosis. Now we have to fix the patient. Let's go back to the inflammatory side. Let's say the EUS confirms the patient has a massive benign pseudocyst. It's the size of a grapefruit. It's pressing so hard against the stomach that the patient can't keep food down, and they are in constant pain. We know it's not cancer. We just need to drain the fluid.
The surgical paradigm for how we achieve this drainage has completely transformed over the last decade. Historically, we talked about percutaneous drainage, driving a tube through the skin,
Leaving a plastic pipe sticking out of the patient's abdomen, draining into a bag strapped to their leg.
It was miserable. The fluid is thick and full of necrotic debris, so those external tubes constantly clogged. Patients would have to flush them daily.
Sounds awful.
Furthermore, because you are creating an unnatural pathway to the outside of the body, it often leads to a pancreatic fistula.
What is that?
The pancreatic juice realizes it has an easy exit route, and it just continuously flows out of the tube, burning the skin around the exit site and refusing to close for months or even years.
Oh, wow. So if we want to avoid that nightmare, how do we drain it today?
We use the exact same endoscopic approach we used for the biopsy, but we go a massive step further. Endoscopic drainage is now the preferred first-line treatment, and we use two brilliantly engineered anatomical approaches: transmural drainage and transpapillary drainage.
Let's break those down visually. Transmural. Trans meaning across, mural meaning wall.
Right. If the giant pseudocyst is bulging directly against the wall of the stomach, the endoscopist uses the EUS to find the perfect point of contact. They use an electrified wire to burn a small hole straight through the stomach wall directly into the cyst.
And then they just let it drain into the stomach. Won't the hole just heal shut in 2 days?
It would, which is why we deploy a stent. And the engineering here is spectacular. We use a device called a LAMS, a lumen-opposing metal stent.
Describe what that looks like.
Imagine a tiny metal dumbbell made of a shape memory alloy called nitinol. The doctor pushes the stent through the hole while it's compressed into a thin wire. Once it's in position, they release it. The inner flange of the dumbbell pops open inside the cyst. The outer flange pops open inside the stomach. The narrow bar of the dumbbell connects them.
And because it's a shape memory metal, it naturally wants to pull itself together.
Exactly. It relentlessly pinches the stomach wall and the cyst wall tightly together, holding them perfectly flush so nothing can leak into the abdomen, while maintaining a wide-open, permanent tunnel right through the middle.
It's an internal biological drain pipe.
The highly pressurized cyst fluid simply gushes through the center of the dumbbell directly into the stomach. It mixes with the patient's normal stomach acid and food and passes harmlessly down the digestive tract.
Wow.
There are no external tubes, no bags. The patient wakes up from the anesthesia and the pressure is completely gone.
That is elegant engineering, taking a massive internal problem and just routing it into the body's existing waste disposal system.
And what about the second approach? Transpapillary drainage.
We use that if the pseudocyst is a bit farther away from the stomach, but we know from imaging that it communicates directly with the main pancreatic duct.
Instead of burning a new hole through the stomach wall, the endoscopist drives the scope down to the ampulla of Vater, that natural exit door we discussed earlier where the bile duct and pancreatic duct meet.
The natural plumbing.
Exactly. They carefully thread a microscopic guide wire up through that natural opening, snake it all the way up the main pancreatic duct, take a turn into the side branch, and drive it right into the cyst cavity.
Okay.
Then they slide a long, thin plastic stent over the wire. It acts as an internal splint, holding the collapsed duct open, allowing the fluid to flow out the way it was originally designed to flow.
It's literally just microscopic plumbing repair, roto-rooter for the pancreas.
And the recovery time compared to open surgery is astonishing. Patients often go home the next day.
Incredible. So that's how we cure the inflammatory pseudocysts.
Mm-hmm.
But let's pivot back to the truly terrifying side of the coin, the true cysts. The neoplastic ones. Let's imagine a patient has an MRI, and it shows a branch duct IPMN.
A mucin-producing cyst in a side channel.
Right. It's a true cyst. And we know it has malignant potential. It could turn into cancer. But it's small. It's only 1.5 centimeters. The walls are thin. There are no solid nodules. The main duct is perfectly normal. It doesn't have any of those high-risk features yet.
Okay.
The international consensus guidelines say that for this patient, the prescribed treatment is active surveillance.
Yes. We don't operate, we watch it. We bring the patient back every year or every 2 years for a dedicated MRI to see if it changes.
And here is where I have to deeply push back, because from a basic human psychology standpoint, this sounds agonizing.
I know, it does.
If an MRI shows a potentially precancerous time bomb sitting in my pancreas, and my doctor sits down and says, we aren't going to do anything, we're just going to watch it for 5 years and see what happens, how does the doctor justify that?
It's tough.
More importantly, how does the patient sleep at night? If it might turn into cancer, why not just immediately cut it out and be done with the anxiety?
This is one of the most difficult, emotionally fraught conversations a gastroenterologist has with a patient. The anxiety of watching and waiting is immense. But the medical reasoning comes down to a brutal, unflinching calculation of risk versus reward.
Okay, explain that.
You have to truly understand the sheer magnitude and morbidity associated with pancreatic resection.
You mean the surgery itself is more dangerous than the cyst?
Vastly more dangerous at this stage.
Nah.
You can't just pluck a cyst off the pancreas like picking an apple off a tree.
Right.
The pancreas is deeply embedded in the major vascular superhighways of the abdomen. If the cyst is in the head of the pancreas, removing it requires an operation called the Whipple procedure.
Explain exactly what a Whipple entails so we understand the stakes.
A Whipple, or pancreatic duodenectomy, is one of the most complex, grueling surgeries in the human body. The surgeon must remove the head of the pancreas, the entire duodenum, which is the first part of the small intestine, the gallbladder, the common bile duct, and often a portion of the stomach.
You are dismantling the core machinery of the digestive system.
And then comes the reconstruction phase. The surgeon has to painstakingly stitch the remaining tail of the pancreas, the remaining bile duct, and the remaining stomach directly into a new loop of the small intestine. They are surgically rewiring the plumbing so the patient can digest food.
That sounds like a minefield of potential complications.
It is. Even at the absolute best, highest volume surgical centers in the world, the mortality rate, the chance of dying on the table or shortly after, is around 2 to 5%.
Wow.
The complication rate is staggering, often exceeding 30 to 40%. The tiny stitches holding the soft, mushy pancreas to the intestine can easily tear, causing massive leaks of corrosive pancreatic juice into the abdomen, putting the patient right back into the ICU with life-threatening sepsis.
Even if the cyst is in the tail of the pancreas, which I understand is an easier surgery, it's still not benign, right?
A distal pancreatectomy, removing the tail, is mechanically simpler, but the tail is where the vast majority of your insulin-producing cells live.
Oh, the endocrine function.
Yes. If we chop off the tail of your pancreas to remove a tiny, slow-growing cyst, there is a very high probability you will wake up as a brittle, insulin-dependent diabetic for the rest of your life.
Oh.
Furthermore, without the full exocrine function, patients suffer severe digestive enzyme deficiencies. They can't absorb fat, they suffer from chronic diarrhea, severe weight loss, and malnutrition.
So, by preemptively operating on a low-risk cyst, you are trading a potential future problem for a guaranteed, life-altering, potentially fatal present problem.
Precisely. And when you look at the massive data sets and survival statistics, the math heavily supports waiting. The biological truth is that these small asymptomatic branch duct IPMNs grow incredibly slowly. Their short-term risk of spontaneously transforming into an invasive cancer is very, very low.
It's a waiting game.
It's a calculated waiting game. If the surgical community decided to operate on every single one of these cysts the moment we found them, we would undoubtedly kill and permanently maim far more people with the scalpel than the cancer ever would have.
So the goal of active surveillance isn't just to be lazy. The goal is to wait until the exact moment the risk curves cross.
Exactly. We monitor the cyst with high-resolution MRIs year after year. We are looking for the exact moment the cyst starts behaving badly.
Right.
The moment it rapidly increases in size, or the moment a solid mural nodule appears inside the wall. That is the biological alarm bell. That is the cyst actively telling us, I am transitioning to invasive cancer.
And that is when you trigger the massive surgery, not a moment before.
That is when the risk of the Whipple procedure is finally outweighed by the risk of the cancer. It is a high-wire act of clinical judgment, but it saves thousands of patients from unnecessary, debilitating surgery.
Wow. We have covered immense ground today. We have travels from the explosive chemical fire wreckage of acute pancreatitis and the body's desperate construction of fibrous pseudocysts to contain it.
It's a lot of information.
We've explored the terrifying physiological breakdown that allows gut bacteria to invade and turn a cyst into a deadly abscess. And we've navigated the quiet, anxiety-inducing world of incidental true cysts, detailing the cutting-edge endoscopic tools we use to diagnose them and the agonizing math of deciding when to operate.
Right.
It is a lot of incredibly dense, high-stakes biology. So what does this all mean? What is the practical, everyday takeaway for you, the listener, regarding this hidden organ?
It really comes down to respect, I think.
Right. The pancreas is an astonishingly resilient organ, capable of defending itself with literal walls of scar tissue, but it is fundamentally structurally vulnerable precisely because of the dangerous chemicals it produces. It is a factory building explosives, and we have to ensure the assembly line runs smoothly.
Exactly. Protecting it means actively mitigating the preventable risks.
Right. We discussed the two primary ways the factory breaks down, gallstones and alcohol. That
Right.
means the absolute best defense is a proactive offense. It's about maintaining a healthy lifestyle, managing a balanced diet and weight to prevent the formation of cholesterol gallstones that can physically block the plumbing. And crucially, it's about respecting the chemical limits of the organ by limiting excessive alcohol intake, which we now know causes those microscopic protein plugs and the direct ductal damage that initiates this entire cascade of misery.
I couldn't agree more. Primary prevention is infinitely better than relying on gastroenterologists and surgeons to navigate the diagnostic muddy waters after the explosion has already happened. The best treatment for a pseudocyst is never developing pancreatitis in the first place.
Well said.
But if we connect this to the bigger picture, if we look at where medicine is heading, the future is breathtaking, especially regarding the management of those precancerous cysts.
You're talking about how we analyze the fluid inside the opaque box.
Exactly. Currently, as we discussed at length, we test the cyst fluid for blunt markers like CEA and amylase. They are incredibly useful. They tell us what type of cyst we are dealing with. They tell us if it's mucinous or serous, but they have a hard limit. They cannot give us the real-time timeline of malignancy. They can't tell us if the cancer will start tomorrow or in 10 years.
But the frontier of diagnostics is shifting away from proteins and moving directly into the source code, molecular biomarker testing.
The cutting edge of research right now is analyzing the actual DNA floating in the fluid aspirated from the cyst. We aren't looking for whole cancer cells anymore. We are looking for the microscopic genetic errors that cause them.
Next generation sequencing.
Yes. Researchers are targeting highly specific genetic mutations in critical regulatory genes like KRAS, TP53, GNAS, and SMA4.
Wow.
These are the exact genetic switches that physically flip a benign epithelial cell into a rapidly dividing malignant tumor cell.
So instead of just measuring the physical size of the cyst on an MRI year after year and anxiously waiting for it to look ugly enough to operate,
We could look directly at the DNA in the fluid and see if the biological switch has been flipped. It raises an incredibly profound possibility for the near future. Are we approaching a paradigm where a simple 15-minute endoscopic fluid draw can not only tell us what the cyst is, but predict with molecular certainty the precise biological moment that benign cyst is beginning its malignant transformation?
it would completely eliminate the guesswork. You wouldn't be doing surgery too early and risking the patient's life for nothing, and you wouldn't be waiting too long and missing the cancer. You could literally schedule the curative Whipple procedure for the week before the cancer actually materializes.
That is the holy grail of pancreatic cyst management. We are getting closer every single day, and it will fundamentally change how we treat this organ.
It would completely rewrite the rulebook. It would take that murky, terrifying landscape of the abdominal cavity and finally map it out with absolute, undeniable precision. The engineering exactness would finally return to the diagnosis.
It really would.
Thank you so much for joining us on this deep dive. The pancreas might be a hidden, volatile factory buried deep in the dark of your abdomen, but by understanding exactly how its machinery works, how it breaks down, and how modern medicine steps in to repair the leaks, you are now equipped with the knowledge to advocate for yourself or your loved ones. Keep exploring. Keep asking the tough questions of your doctors. And remember, sometimes the most dramatic, high-stakes stories are unfolding inside the biology we take for granted every single day. Until next time.